Chairman, and that concludes the opening statements by members of the subcommittee. So we'll now turn to our witnesses, and we have one panel, and you're all seated. So I want to welcome you, first of all, and let me introduce each of the panel members here. First is Dr. Diane Rowland, who is I'm going from my left to right. Dr. Diane Rowland is Executive Director of the Kaiser Commission on Medicaid and the Uninsured from here in D.C. And then to her right is Stephanie Thomas, who's National Organizer for ADAPT and Co-Director of the Institute for Disability Access. And then we have next to her Mr. Ralph Gronfeld, who's President and Chief Executive Officer of ResCare. He's from Kentucky. And then we have from my own state, Celine Fortin, who is Associate Executive Director of the ARC of New Jersey from North Brunswick, New Jersey. And I want to particularly thank her because she was part of a roundtable that we had during the break in New Jersey earlier this week, where I was trying to get an idea of how some of these Medicaid rules are directly impacting New Jersey. So thank you for being here and coming a second time for me. And then we have, to her right is Eileen McCormick, who is President and Chief Executive Officer of Amerigroup Texas, Inc. She's from Bel Air, Texas. And finally is Julie Beckett, who's Director of National Policy for Family Voices, and she comes from Cedar Rapids, Indiana. No, Iowa. I'm sorry, Cedar Rapids, Iowa. I should know that after the Iowa caucus. Let me just mention we have 5-minute opening statements from the witnesses. Those statements will be made part of the hearing record. Each witness may, in the discretion of the committee, submit additional brief and pertinent statements in writing for inclusion in the record. And I'll start by recognizing Dr. Rowland. Thank you.
Thank you, Mr. Chairman and members of the committee. I'm very pleased to join you today to discuss the evolution and current role of Medicaid for people with disabilities and the many challenges we have in meeting the diverse and extensive service needs of this population. As you well know, the Medicaid program is our nation's major public health coverage program, today covering some 58 million low-income Americans, including 8 million persons with disabilities and 6 million low-income, frail, elderly, and disabled Medicare beneficiaries who rely on Medicaid to fill Medicare's gaps. Medicaid is indeed a vital safety net for millions of Americans, but a lifeline for many people with disabilities. Since its enactment in 1965, Medicaid has been a predominant source of assistance to people with disabilities. Over the years, a national floor for eligibility and common definition of disability was established with the implementation of the Federal Supplemental Security Income Cash Assistance Program in 1972. Assistance in the community and at home became more available as an alternative to institutional care over Medicaid's history. Improvements have been made in the quality of care in nursing homes, and assistance was provided to enable people with disabilities to return to work while retaining Medicaid coverage. To be covered by Medicaid, individuals must meet, however, both restrictive income and asset requirements and have a condition determined to be permanently disabling. The average income level for eligibility is $7,500 a year with an asset level of $2,000, those embodied in the SSI Cash Assistance Program. As a result, Medicaid is unable to cover people at higher income levels. The Medicaid disability population is diverse with a wide range of conditions and limitations, including children with intellectual and developmental disabilities such as mental retardation and autism, young adults with spinal cord and traumatic brain injuries, HIV/AIDS or serious mental illness, and older people with Alzheimer's or severely disabling chronic diseases such as diabetes and pulmonary disease. The needs of people with disabilities are extensive and complex, requiring many types of health services and supports that are not traditionally covered by other sources of insurance, but needed to maintain function and, in some cases, independence. Of the $103 billion in Medicaid spending for people with disabilities in 2004, 38% was for long-term care services, 19% for prescription drug coverage, and 43% for medically related care, especially including mental health services often uncovered in other programs. Medicaid's strength has been its ability to provide a continuum of care and a wide range of supportive services. Although Medicaid is principally recognized as a source of health insurance coverage for millions of low-income children and parents, the program is indeed the largest source of health insurance and long-term care for people with disabilities. Seniors and people with disabilities comprise only a quarter of enrollees in Medicaid, but account for 70% of all program spending. The average per-person cost for persons with disability in 2004 was $12,364 compared to less than $1,500 for non-disabled children and a per capita expense of less than $2,000 for non-disabled adults. Moreover, the concentration of spending is very linked to high-cost beneficiaries. High-cost disabled beneficiaries incurring over $25,000 a year in expenditures represented 2% of overall Medicaid enrollees, but accounted for 1/4 of all program spending. Medicaid plays a critical role in providing health services to people with disabilities by filling in the gaps in Medicare and private insurance and going beyond the medical model to offer the broad array of services needed by people with severe disabling conditions. Doctor visits and prescription drugs alone are insufficient to enable an individual with severe paralysis to get a job. Personal assistance, medical assistance devices, transportation, and other assisted devices, all covered by Medicaid, are essential adjuncts to medical care. Extending eligibility for Medicaid coverage to individuals without requiring impoverishment can help to stimulate broader access to community-based care and enable people with disabilities to work without fear of losing the Medicaid supports they need to function. One of Medicaid's biggest challenges, however, in meeting the needs of people with disabilities has been that there are differences in functional and financial eligibility criteria between nursing home and community-based care that has steered people with disabilities into institutional settings. Consumer demand and the Olmstead decision have helped to promote expanded access to home and community-based services. Through home and community-based waivers now, Medicaid is helping nearly 3 million people to be able to receive care in the home rather than in an institutional setting, but more options are needed. Some 280,000 people were on waiting lists for home and community-based services in 2006. Institutionalization should not be the admission ticket to home-based services under Medicaid. The Medicaid experience, however, clearly demonstrates the importance of providing a broad range of health and long-term care coverage for the population with disabilities and documents the lack of alternative forms of assistance. Reformers should build on the progress that has been made in providing coverage and access to care with those with disabilities and exercise extreme caution when making changes that could affect the health and well-being of many of our nation's poorest and most disabled citizens. Thank you very much.
Thank you, Dr.